Hi, I'm Dr. Brian Kaufman, a CLL patient myself, retired family doctor, and the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society. Dr. Hyman?
Heyman. I'm a physician at UCSD, a hematologist, and focus on treating patients with CLL. It's a pleasure to be here with you today, Dr. Kaufman.
So we're using the magic of Zoom to catch up post-ASH, and you had a very interesting presentation where you were the lead author on a paper on a drug that members of the CLL Society community have heard about, Cirmtuzumab, and remind us what Cirmtuzumab is and its target and why that's important to CLL patients.
Sure, happy to do that. So Cirmtuzumab is a monoclonal antibody that targets a novel stem cell antigen called ROR1. And so ROR1 is a embryonic stem cell target found on many different malignancies, both hematologic like CLL, as well as solid tumors, so breast cancer, ovarian cancer. And we have found in our research, both in CLL as well as in solid tumors, that in those tumors that express kind of stem cell markers, so that resemble more like embryonic stem cells, that those patients that have those markers on them, they typically have more aggressive cancers. They're typically more likely to have metastases, and they have inferior prognosis compared to those that don't have don't have these kind of stem cell markers. And we term this something called stemness. How much do these cancers resemble stemness, or have these stemness signatures? And so ROR1 has been kind of found to be a major player in this stemness signature. And so typically ROR1 is not found on normal healthy cells. And so it's an attractive target in that it can potentially, for therapeutics, because we can potentially target the cancer cell while sparing any healthy tissue, which has been a problem for a lot of our treatments for patients with cancers in general, and that while we target the cancer, we unfortunately, as a side effect, target normal healthy tissues, which causes the side effects. So Cirmtuzumab is as an antibody that is very specific in targeting ROR1.
So,
Patients with CLL as a single agent. Sorry.
Yeah, no, go ahead. We just lost the audio there for a second, but could you just repeat that last
Sure.
sentence for us? Yeah.
Oh, yeah. So, and so Cirmtuzumab has been studied for now in several different cancers, but probably most extensively for patients with CLL as a single agent, as well as in combination with ibrutinib. Has been shown to be very safe without really any significant toxicity associated with it. It has been shown to have, when we look at kind of in-depth kind of biologically, it's been shown to be have very good target activity against ROR1. And it's been able to show that if you treat patient samples, we're able to actually reverse the stemness signature, we call this, and to be more like a more differentiated appearing kind of more differentiated cell. And so potentially can overcome some of those factors that mediate treatment resistance.
So when the cell is more differentiated, that means it's more mature and less likely to misbehave and tends to be a less aggressive malignant type cell. So is that a simplistic understanding of that?
Yeah, so it seems like that when cancer cells are more differentiated, they're more likely to have, less likely to have less likely to have metastases, less likely to be resistant to our therapeutics, and hopefully less likely to misbehave, correct? And so what we've been really interested in is looking at this, looking at kind of modes of in patients with CLL, trying to look at this idea of for patients who are now treated with targeted therapy, specifically both venetoclax and ibrutinib, and for this trial specifically venetoclax, saying we know that some patients who are treated with venetoclax either by itself or in combination with anti-CD20 monoclonal antibodies such as rituximab or obinutuzumab, about 2/3 to 3/4 of them will essentially get to a very, very deep remission, which we call kind of undetectable minimal residual disease, which means with our most sensitive techniques, we cannot find any evidence of the leukemia. However, there are a subset of patients, either when they're treated initially with venetoclax or in the relapse setting, where some patients aren't able to achieve this undetectable minimal residual disease state. And for them, after they stop their venetoclax therapy, they're going to be they're at higher risk for having relapse of their CLL versus those patients who are able to achieve this undetectable minimal residual disease state. And so we were really interested to see, well, could kind of ROR1 and stemness play a role in this kind of resistance to venetoclax? And so some of the preclinical work done in the laboratory of Dr. Kipps through the work of Emmanuel Aguilla demonstrated that if we looked at patient samples kind of who were treated with venetoclax-based regimens, and we compare the patients who achieved undetectable minimal residual disease versus those who were not able to achieve undetectable minimal residual disease, we saw that those patients who were unable to achieve undetectable minimal residual disease actually, in part, were found to have increased expression of ROR1 and had higher stemness gene signatures compared to those patients that didn't. They also had higher kind of risk factors, such as high risk cytogenetics, kind of the high risk chromosome abnormalities, and some higher, and also were found to have mutations in BCL2. And so this led to the hypothesis that said, well, for patients who, the smaller subset of patients who don't achieve undetectable MRD, can we potentially give them Cirmtuzumab at the completion of their kind of venetoclax therapy, whether it's a year or 2 years, and see, can we then potentially convert them from to undetectable MRD and improve their long-term survival? To start a clinical trial here. Sorry. We've been able to start here a phase 2 clinical trial here at UCSD, where essentially we're looking at this kind of subset of patients who've been treated with venetoclax-based treatments for CLL, whether initially or in the relapse setting. And after at least a year of treatment, if they have a detectable minimal residual disease, then they will go on to, we would then add this antibody called Cirmtuzumab to their treatment for a period initially of at least 6 months, and see after 6 months of Cirmtuzumab, have we been able to convert them to this undetectable minimal residual disease. And for those patients who are able to, who have achieved undetectable and minimal residual disease after Cirmtuzumab, they could go on to receive another 6 months of treatment for a total of a year if they wanted to.
So where is that trial at right now? And I think I understand it's very early. Do you have any preliminary results? Have you seen any safety issues? Any do you have anything in terms of efficacy that you could report at this point?
Sure. And so this is a clinical trial in progress, so it's only recently be open. So we don't have any efficacy data to report at this time. But the trial is open. We certainly have several open slots for enrollment if patients or providers are interested in being screened for eligibility, and we're more than happy to have patients. And with regards to safety, like I said previously, Cirmtuzumab, because it targets ROR1, which is again typically not found on normal healthy tissues, we really haven't found in the patients who have been enrolled this far, even with in combination with venetoclax, we really haven't found any new safety signals with Cirmtuzumab thus far. I mean, generally, it's usually a very well tolerated medication with that typically patients don't have significant side effects from. And thus far, really no new safety signals, at least thus far in the patients we've had.
So we'll be sure when I do the write-up on this interview to include a link to the actual clinical trial through clinicaltrials.gov, and that'll give them a way to contact your investigation team and be screened for the trial. And any,
Great,
yeah,
great.
it does seem to me that this is a direction things are going in, is moving towards getting as far as you can with maybe one medication. And if you don't get to where you need, adding in a second medication and using undetectable, and I like to call it measurable residual disease rather than minimal residual disease, but getting to that point and then being able to stop. That this seems to be a trend, and not just the Cirmtuzumab, but there's other trials that are looking where, you know, adding ibrutinib to venetoclax, and there's a trial that looks at these kinds of things, and it just seems like a direction that that CLL treatment is moving in, and it's good to see a very focused agent as part of that mix.
No, I think we're very excited about the trial here, and so would be very excited if anybody who would who'd be interested to contact us to talk about it from anywhere. And I think yeah, I think ASH as a virtual meeting issue was really exciting. I know I saw some commentary from you on the on the sidebar, so I was very excited to see that. But yeah, thank you so much for having me, and yeah, and I'm happy to anytime to come back and talk to CLL Society anytime.
Yeah, thank you so much for the research you and the team with Dr. Kipps and Dr. Choi are doing down there. It's so important. Thanks so much.
Thank you.